KRT-232 is a very potent MDM2 inhibitor, and our group has done some of the initial work with Idesinotlan, which is an oral MDM2 inhibitor, initially in PV patients that demonstrated, that MDM2 is upregulated in MPN patients. It negatively regulates the p53 pathway and is a therapeutic target in MPNs. In PV, with Idesinotlan, we saw hematologic responses and even molecular responses. In MF, KRT-232, in the study that's ongoing, has shown spleen and symptom responses in patients who have failed Ruxolitinib previously. Similarly to Idesinotlan in PV, it appears to have clinical activity that is based on the fact that MDM2 is upregulated and negatively regulates wild-type p53, which is usually the case in chronic phase myelofibrosis. The next iteration of this MDM2 development in myelofibrosis is a combination phase study of KRT plus Ruxolitinib in patients who have advanced myelofibrosis, as there is preclinical data that two drugs could work well in concert together. The drug is also being explored in polycythemia vera, as well as patients with advanced phase myelofibrosis that are in blast phase or have secondary acute myeloid leukemia, in which the outcomes are dismal. Again, this drug would target patients who have wild-type p53 based on the principle of turning on this pathway and selectively inducing apoptosis in the stem and progenitor cell population of the malignant cell, malignant MPN cells within the bone marrow. It's an exciting approach and is a class of agents, including KRT, that I think people should look at and consider, particularly referring patients who have failed Ruxolitinib, who need second-line therapies, in which we know the options are limited and the outcomes are poor.